Afternoon, everyone. My name is Walter. I work with AMREF. I'll be moderating this afternoon session, so I will request that we keep our questions coming, and I will be able to answer as we come to the end of the presentation. So may I ask Dr. Sitonik, you can introduce yourself also?
Okay, thank you. Let me remove that. My name is Dr. Sitonik with AR Healthcare, head of clinic business operations, and I'm glad to be part of this discussion today.
Thank you, most welcome. Leah? Okay. Maybe she's not yet back, but Dr. Joanne, back to you as we start the process.
Okay. Good afternoon, everyone. My name is Dr. Joanne Osorombui, currently serving with the HRH Committee of Kenya Healthcare Federation. And it's my pleasure to just provoke us even as we process how to navigate through the COVID-19 pandemic. Thank you very much.
Okay, now, so we'll go back straight to the presentations.
Okay. Okay, so I will start by just doing a recap of what we did last week, just to remind us, for those who had not joined us. Today we are doing part 2 of the Swiss cheese model in managing COVID-19. Let me just put this to slideshow. Yes, and just to remind us what the Swiss cheese model is, it's basically slices of cheese with different holes, and the slices of cheese are multiple defense layers of a system against any harm. And the holes are breakdowns in the safeguards, and if they're aligned, they lead to hazards or losses, which are preventable if not aligned. So we'd mentioned where this has been applied. It's really applied in very high-risk industries like aviation, marine, healthcare, defense, nuclear, gas. And it's useful in helping us enhance rational decision-making to improve our systems, which are continuously evolving. And it's been used in healthcare in a number of conditions and situations. So we talked about what active failures and latent failures are. And active failures are unsafe acts by healthcare workers and the public and enforcers, slips or lapses or fumbling. And then latent failures are in the administrative level decision making, error-provoking conditions where people don't feel supported, or long-lasting weaknesses like weak health systems or poor or ineffective communication. And then the character of a system. Are we a system that's dormant, proactive, or reactive to whatever harms come our way? So we also went ahead to talk about the losses we are hoping to avoid. And the first one was the loss of life due to the pandemic, but I need to add loss of life due to ignoring other people who may not be suffering from COVID-19. Loss of human resources. There's the real loss whereby our healthcare workers fall ill, but there's also the quasi loss, which could come from maybe people going on self-quarantine because they're unwell. But in the past week or two, we've seen real loss of work by healthcare workers abroad in the US, in the UK, because we are not giving any other elective services. Then increased infections, loss of economic ability, loss of confidence in the governance and health system, and then finally, hopelessness and despair. So we looked at two main areas. Last week, we focused a lot on the public health or community initiatives, and we focused a lot on testing, tracing, treating, and training. And today we are hoping to focus on healthcare facilities where we are found. That's admission criteria, healthcare worker protection, and continuum of care. So we looked at the holes in the public health and possible concealers, and we had very good discussions from the team. So for testing, we looked at the fear of forced quarantine in case people turn positive, increased testing for all who are hospitalized, and fear of isolation. And we really spoke about the need to keep on telling people the importance of microdroplet spread and why we need then to have social distancing, wear face masks, hand hygiene, so that we can prevent this. We talked about clear protocols on isolation of asymptomatic patients, and we'll pick up on that again today, and psychosocial support during isolation. And this really came about because of the people we had seen running away from centers like MTC. Then in terms of tracing, roads infrastructure, communication, that is ongoing. Treating, we looked at the pharmacological treatment whereby we have continuous update on protocols that are evolving with each day. We looked at psychosocial kits, psychosocial support, and then PPE kits and knowledge of hospital expectations to manage anxiety. Then finally, in training, we discussed the importance of the self-quarantine protocol because many of our patients require to go on self-quarantine, managing community spread, and daily updates from the CS, who has been very faithful in that regard. And finally, use of community health volunteers who have been put on board now. So let's go on to today's presentation. And we just want to look at the slices in service delivery or in healthcare facilities. And we chose to look at them in these three broad areas. There's the admission criteria. We have asymptomatic patients who form about 70 to 80% of the patients who will come. And then we have those with mild illness, and then who form another about 10 to 12%. And then we have patients with moderate illness who form about 3 to 5%, and critical illness, which has been noted to form 2% of the patients who come in. Then we have healthcare worker protection. And this we will look from an area of what knowledge do we have about it, what attitudes do we have, and what are we practicing on the ground, and how can we improve it. And then the continuum of care, we need to look at shared decision making, first do no harm, and then vaccination. So what holes are there? And we thought it will be important to review who are the patients who require admission. This has become an area we need to really consider. When we got COVID-19 in Kenya the first time, any patient who had symptoms or even was asymptomatic was being admitted into the hospital. On average, we have noted that the length of stay falls anything between 18 to 23 days because we do the first test to check for negativity after 14 days to make sure the patient is better. And there are many whose tests are turning positive, in which case we give them an additional 7 days before we repeat the test. But now with increased mass testing, which is an excellent initiative, because it's in increased testing that we hope to get increased, or rather catch any cases to be able to flatten the curve. We have found that we have cases in our more populous areas like Dagoretti, Kawangware, and Isili. And so therefore the question comes, who requires admission? Will all these patients go to MTC or Kenyatta University Teaching and Referral Hospital? What if they're asymptomatic? Do we keep them in the homes? Do the homes have enough ventilation? Are the homes crowded? And these are questions that we have to ask ourselves and really think through what's the way forward. And then finally, what's available? It's a good thing we've gotten the community healthcare workers on board, but are we using them sufficiently? And one of our leading public health specialists 2 weeks ago was saying, you never fight public health issues by enforcing the law. You fight public health issues by involving public health officers. And so we'll be looking at that and seeing what are the options that we have. So in regard to moderate illness, the patients usually are admitted to receive care. The protocols are being communicated all through, and critical care, I think we've seen some excellent innovations in terms of ventilator provision and other things. In regard to healthcare workers, knowledge, are we familiar with policies, protocols, and guidelines, not just of the treatment, but of how to also care for ourselves? About 4 weeks ago, we shared how to care for ourselves as healthcare workers, how to expose ourselves or not to expose ourselves. And this was followed again by Professor Atwoli's presentation, which just emphasized the same. What attitude do we have? And this attitude could be as a result of our understanding of the policies and protocols that are available, and then the availability of PPE. And this, Dr. Sitonik has been very clear. One thing we need to know is not everyone needs to be dressed like someone going into space. If we are not in a critical area setup where we are not doing bronchoscopy, then just having an apron, a face mask, and gloves suffices. We don't have to wear a coverall so that we can be safe. So what PPE is there, and what do we know is supposed to be worn wherever we are? Then logistical support, this we've discussed significantly. Going home and coming back to work, do we feel safe? A lot of work has gone into ensuring that people have the right identification so that when they are stopped on the road, they do not have very many challenges with our officers of the law. But then the other thing which we challenged ourselves was releasing our healthcare workers in good time. And for those of us who have the capacity and capability to be able to host our workers in the hospitals, maybe our nursing schools, then that has been an option that has been explored. Psychosocial support, and the paradigm shift that there is in how healthcare is running. Right now, many patients are fearing to come to the hospitals because they do not want to pick COVID from the hospital. And therefore, our numbers have greatly reduced. Do we need to rethink how we provide healthcare? And the options of telemedicine have been excellent, but there are things that require more than telemedicine, and we may need to think further. How do the patients then monitor themselves? And we use things like iPhones and Android to be able to tell our vital signs and all. And then finally, mass testing of healthcare workers for better self-care. This again has been launched out. It's still a work in progress, but is it achieving the desired results? So those are some of the questions that we need to ask ourselves. Then finally, in terms of continuum of care, what are the things that are affecting continuum of care? There's the anxiety, because one, how long does it take to get better with COVID? 2, why can't I get immunity from COVID? 3, can I be vaccinated to prevent this? 4, when I go home, do people run away from me? Do people want to avoid me? And then finally, what happens to me who used to go to the hospital regularly? Our pregnant women, our children for immunization, patients with chronic illnesses, and urgent cases, not emergencies. An acute appendicitis may manage to make it, but what about a subacute one? And will that patient come to the hospital with fulminant sepsis? Are we setting ourselves up? And so just as we process some of those things, some amazing thoughts just to help us think through include, just as we go to the next slide, for patients who require admission, what is available? Right now, the challenge we have is to figure out what are the self-quarantine rules or institutional quarantine rules, especially in our more populous areas. Like I mentioned, places like Isili and Kawangware. Do we need to start training the people who are in those places? We've done a lot of work in terms of training hotel workers, because that was the next port of call. But will we take those people to hotels, or are we better off using schools? And if we use schools, we cannot then have an example like what we had in the media the other day of a mother with a child on a carton box. So what is the minimum that we require? And we've had some very good feedback and goodwill from people who are donating mattresses like Bob Mill, and we need to think, where do we take these mattresses so people can actually quarantine in those institutions where we have enough ventilation to prevent the microdroplet spread, and then ongoing treatment which is there. The other thing in terms of healthcare workers, the protocols are ongoing in terms of review and improvement, and both the Ministry of Health website and the Kenya Healthcare Federation websites have those guidelines and protocols for us to be able to access. In terms of PPE provision, local provider contacts are being uploaded on the Kenya Healthcare Federation website so that people know who are the reliable suppliers for our N95 masks, our aprons, our gloves, so that we are safe, even as healthcare workers. But even more importantly, this research came out yesterday from Harvard. They have discovered you can actually microwave your N95 for about 3 minutes and it will remain safe and intact for reuse. So even just looking out to find out what's the latest research that's coming out that can enable us to push whatever we have a little longer so that we can be able to remain safe. Ongoing trainings on specific protocols, infection prevention control are ongoing every Thursday and Friday from 2 p.m. to 4 p.m. Walter, who's logged on here, is the facilitator for that. And I'd just like to encourage us to log on to that, because then it enables us to stay in touch with what's going on. And we are scaling up testing. So we need to continue scaling up testing, not because we fear there are cases that are not being missed, but just to enable us be more vigilant and proactive in our measures in control, because without knowing, then people perish for lack of knowledge. An interesting statistic, we discovered Italy has reported very many cases, but for them, any patient who has symptomatology of COVID, irrespective of whether they've been tested or not, is being counted as a case. And what that's doing for them is making them be more vigilant. So we need to be more vigilant as well, even in our care of our patients and looking out for them. Now, finally, in terms of continuum of care, shared decision-making is very important. And as healthcare workers, we have been used to having patients run to us. And now the stakes have changed. We are the ones who need to run to our patients who we have had and ask them, have you taken your medication? How are you feeling? That's a slightly higher cost on our end in terms of effort and communication. But it's the only way we'll ensure that we do not have a scenario like we had during Ebola, where Ebola killed 11,600 people, but 10,300 died of other illnesses because they were forgotten. And therefore, shared decision-making is key for our non-urgent chronic patients or patients who are like pregnant women and children who need to be seen. We need to make them know that it is safe to come to our institutions, only that we need to schedule for them to come to be able to get care. The other thing that we need to talk about is first, do no harm. And this is a conversation that has come up again after looking at the SARS-CoV, the MERS-CoV pandemic of 2003, where they realized that a lot of the things that we were doing were very experimental, not based on any science, mainly because one, we didn't want to watch people die. Two, we needed to do something so that people also have an element of comfort. And therefore, ribavirin, which is an antiviral that was used during that time, caused hemolytic anemia in 30% of the patients who were put on that medication. And so even as we continue with treatment, I think it is imperative that as healthcare workers, we ask ourselves, is this beneficial to the patient, or am I just giving this for the sake of giving it? Because the first thing we are all mandated to do is first do no harm. Hence the reason why we will say, if you have metastatic cancer, I will not go giving you strong chemotherapy. I'd rather give you pain medication, give you nutrition so that I can support you. And this also supports the issue of vaccination. We all would like to be the test cases for the vaccination, but it's a good thing that the WHO Director General said Africa will not be a testing ground for vaccination because of the same thing I said earlier, that when it is not done based on the ethics that are there to guide vaccination development, then we will expose our people to more harm than good. And therefore, even as we wait for vaccination, it's interesting that discussions amongst immunologists were revealing that one of the reasons that maybe the cases are not too many in a place like Africa compared to the West is we have been giving BCG vaccine. Could it be conferring some form of immunity? Europe and the Americas do not give BCG because they had eliminated tuberculosis. But could it be conferring some immunity? And even as they do their research and try to find out what's going on, I think for us, the best thing to do is just continue to be vigilant, noting that when you have pandemics, it's the public health initiatives that are our saving grace. And then where the patients must come into the hospital or healthcare facilities, then we can be ready to give the best that we can, but remembering that first, we do no harm. So I think I hope I have whetted your interest, and look forward to hearing any comments, questions, concerns. Thank you all.
Wow, thank you, Dr. Now, we've had a very nice presentation. That is very wonderful. Panelist Ken has joined us. Ken, say hi.
Good afternoon, panelists and participants at large. My name is Ken Auma from Medical Records Institute and the chair of a Human Resource Committee at the Kenya Healthcare Federation.
Thank you, Ken. Thank you. Thank you. Now, as we come to now the next session, I request participants, please keep your questions coming. We'll be able to answer, and the panelists will be able to address them. Meanwhile, Dr. Joan.
Yes.
Give us an insight of what has come up following now the presentation of Dr. Joan.
Oh, I think you must mean Dr.
Oh, yes, sorry, Dr. Sidoni. Yes, Dr. Sidoni. Yeah. Sorry for confusing.
Okay, thank you so much. Yeah, thank you so much, Dr. Jawan, for that good presentation. And also, I'm so used to having this on, but thank you also, Walter, and my fellow panelist, Ken, for coordinating this presentation. So I think this is a very timely discussion, especially as we try to work with what the Ministry of Health is saying, where we are telling patients that if you really need to go to a hospital, if you're sick, you're better off going to the hospital as soon as you feel unwell rather than waiting until things are really bad. Because the truth is we are seeing more and more patients coming in very advanced stages, all because they fear going to the hospital. So the Swiss cheese model, especially as we look at returning back to a new normal, is very timely, and it will be one key area that we need to address as we look at the patient journey across right from entry all the way to getting all the different levels of service, and also give them and thereby give them the confidence that it is safe for them to continue getting care at our facilities. So this is not the time, as the Ministry of Health has been raising concerns that people are looking laxed and maybe not following the infection prevention recommendations that have been done, especially in the public, for the general public. But in the hospitals, this is exactly the time we really need to pull up our socks in ensuring that infection prevention measures are applied very closely in our outpatient centers, right? And that is through mapping of the entire patient journey across our centers. So right from admission, I'm seeing somebody asking how do we handle patients who are asymptomatic, who maybe have come for other health services. It again now goes to the next one from after the admission criteria, which could be either in the OP or in the IP, how the healthcare workers are protected. Because as we had agreed last meeting, in the last discussion that we had, is right now we should be looking at our operations as if we are dealing with the possible carriers with all our patients. So safety has to be maintained 100% of the times when we are handling our patients, be it wearing the surgical masks, be it sanitizing or washing hands before examining the patients and after, be it reviewing our processes to see whether there are some processes that enhance transmission, like for example, signing in. Does everyone have, how can we do that without having too many people touching the same things, for example? So it would mean that, one, our processes should assume that everyone could be a carrier, and two, our processes should review whether they put our patients more at risk of cross-infection or cross-transmission within the hospital facility. And then we would need to look at how to overcome that barrier and still enable them to get the services as is required. Continuum of care, as Dr. Joanne had said, would largely be based on patients feeling safe within our facility. So again, it all comes back to different aspects of these discussions, which all link up together to take us back to the new normal. Thank you.
Thank you, Dr. Sitonik, for that input. Dr. Joanne.
Yes.
Now, Dr. Sitonik has just answered a question of how to identify those who are just having COVID, but they are symptomatic completely. Now, how do you address the issue of client flow in terms of entering facilities so that they're able to identify? Because this is a big challenge that many facilities are actually handling. And the second question is, how is suspected cases being handled at facilities before they are being transferred, or action being taken to the isolation facilities that are provided in each county?
Okay, so maybe we start with the patient flow. Yes. Just like the normal care of patients, in a pandemic as well, we need to delineate and have a different pathway for patients who are suspected to have COVID and patients who are not suspected to have COVID. I think we've seen a number of, actually many of our institutions have already put that in place many months, whereby as everyone walks in, and this is also being implemented even hotels, you have their temperature being taken and a short history. And now, of course, travel history no longer applies because we are having a lot of internal spread within the country. So just that history and checking the temperature, and of course knowing that your thermometer is an appropriate one and it's able to pick the temperature, and remembering it's retroauricular, because in a hot day, on a hot day, if you do it at the forehead, you will all have fevers. And I remember there was a time our Governor Joho in Mombasa panicked when there were so many people whose temperatures were high, but technique of temperature picking is very key so that we are able to delineate those who fall within the case definition of symptomatology and having a high fever, then should be directed differently to where they will be isolated and further testing conducted. Once that is done, then thankfully now the tests take on average about 3 to 6, 7 hours so that we can be able to give patients feedback. And this is especially in areas that are doing the testing. I know currently the ministry has 15 testing labs across the country. We are still behind, but it's great milestones made. So patient flow is important. Delineate that the patients who fall in the case definition are moved to a different isolation area where there needs to be comfort. And in comfort, I mean, if you're able to provide things like Wi-Fi or be able to give snacks, let them be able to have contact with the healthcare workers in one way or another, even as they wait for their results. That's how you deal with the patients. If then the suspected cases have to stay longer, then institutions must have provision. And I remember when COVID began and we would wait about a day or two for the results, any patient who had symptoms, even if they were mild, we would keep them in our isolation area in the hospital. And we would treat them like you treat any other patient who's admitted, only that they're in an isolation area. We limited a lot of contact so that, again, their cost of care, since they were mild symptoms, would not increase, because these are not people who anticipated to come in and get admitted. So having a different pathway is important, and then also being able to give them comfort and care during the time that they're waiting for their result. Constant communication to manage expectations is very key. And I remember as soon as the ministry will tell us possibly 6 p.m., we'll tell them we are hoping for 6 p.m. If it delays, then we'll tell them we are still waiting. As soon as we have information, we will be able to share with you, just so that we could manage the anxiety. Because one of the things we also noticed is, besides the flu-like symptoms, which may be relatively mild, anxiety became a bigger problem. So many of our patients had to go on anxiolytics, and if they happen to spend the night, there are times we would have to give them sedatives just so that they can rest, waiting for the results the next day. Yep.
Thank you, Dr. Chuan. I think that is quite comprehensive. There are many questions that are coming. Yes, we are looking at, even in terms of actually addressing the loopholes and the gaps that exist in terms of the holes. Now,
Yes.
one participant texted me directly saying, is the Swiss model an example of a quality improvement intervention?
The Swiss model is a form of not just quality improvement, but also prevention of harm and further losses outcome. So it's been used both ways. And the very key thing about the Swiss cheese model is it encourages us to keep looking at what are our slices, because if we don't get it right at the design level, we will constantly be wondering, are we going to get another spike in the curve of our COVID-19? And the other thing about it, it enables us to contextualize our solutions. We cannot use the solutions, for example, that have been used by Germany because it's a different economy. They are industrialized in a different way, and the resources they have, I mean, right now they're focusing on vaccine development, while here we are saying we still do not have sanitation. You know, there are places that still do not have water. We are saying, what do we do? And therefore, the Swiss cheese model helps us to focus on who are we as Kenya, as a country, what are our unique challenges as Kenya, and then how do we respond to those challenges as Kenya. And if you notice, I kept referring to the current challenge we have of now patients testing positive and asymptomatic in places like Isili or Kawangware. So you may not find that crowding in Germany, for example. So they will never give us a solution to it. If you look at Soweto in South Africa, it's a slum, but it doesn't look like our slum. So their solutions will not be our solutions. And therefore, that's why this model is very key, because it helps us to contextualize our solutions. And therefore, when you see people like Bob Mill Mattresses or Bridges School are donating water tanks so that facilities and institutions have clean water, because we know hand hygiene is key, or supplying mattresses after seeing a lady with her baby on a carton on a floor because there was a double decker without mattresses, then those are local solutions for us that actually make a difference. And so that's why the Swiss cheese model is excellent at contextualizing what we do. Yeah.
Thank you. Thank you. We are receiving a few questions. Yes. Ada had asked about how do we identify those who have actually COVID positive? Yes, but they are symptomatic. You've explained. In terms of presentation, the participants, someone is asking, how can they be able to get these presentations for further reference?
I think for now, the presentation will be on the Kenya Healthcare Federation website. So the members, I mean, you can log on. I think Dr. Sitonik may remember the website or the email address better, so that you can be able to do that. So that you'll be able to get, yeah.
Thank you, Dr. Sitonik. Anything to add?
Yeah, I think just to emphasize on a point that Dr. Jawan has just mentioned is that we have, even in our hospitals, unique ways in which we offer services and in which patients access services, such that protocols may be given by, say, WHO, or even from hospitals where we are trying to exchange knowledge, say from China, from how they are doing it in Europe or in America. They may not address some of those processes in our hospitals and our outpatient centers. So when you have a model like this, it is usually very useful in now creating your own guidelines in our institutions. So I think this was really just to give, especially if the participants who would probably be supervisors or managers, a framework with which they can approach the process of creating local solutions for patients, and also for ensuring that our staff are safe. Yeah.
Thank you, Dr. Sitonik. Thank you, Dr. Joan. I think the presentation has been very clear. Questions are not as many as we expected. From the way I understood this model can be applied both in public and private, can also be applied in big and small facilities, as small as a clinic and as big as level 6. So it is something that can work even at the level of department.
That's true, Walter. Yeah, and I hope it helps people just narrow down to where they are and see how to respond. So it's really to empower us to know how to respond and be very specific about what works for us in our institutions.
Thank you. Thank you, Victoria. To all panelists, she's saying thanks, Dr. Joanne, for the great summary. They are really understanding this and they will be able to intervene at their level of facility. So everyone seems to be happy about this. Ken, is there something you want to add?
Yes, thank you, Walter, and Dr. Joanne and Dr. Sitonik on the same. Now, as we look at the slices and the holes, and I'm trying to think as now from the public side, the people are back in business as usual, as if there's no corona. The hotels are fully and packed as if there's no corona. The hospitals are almost shutting down as if there's a lot of corona there. So how can we then inform the public using our slices that the hole they are seeing is a different one from the one that we are assuming exists? Because now people in the streets are walking as if there's no corona, but they fear the hospital. Is it that they think the hospitals have corona, or the advertisements say don't go to the hospital until you're called? Yes, Dr. Joanne?
You know, Ken, that's a really tough one. I was hoping no one would ask that question, to be honest. But it is spot on, and it is currently very topical. It's something we have struggled to see how to respond to. And I think this is a discussion we were having where we were saying, was opening the restaurants the best way to return back to normalcy, or should we have done something else? And one of the challenges and one of the things that we need to do or should have done was, one, if we understand that the challenge with COVID-19 is microdroplet spread, then if we look at many of our restaurants, they don't have many windows, number one, which means we have the air that we breathe remaining static. In fact, one of the first cases we treated in the hospital was somebody who had traveled back from the country, back into the country, spent 3 to 4 hours with friends and family at a restaurant. And some of those people turned asymptomatic, but they had to be quarantined, self-quarantined at least, because they were asymptomatic. And the proximity with which we sit in an eatery is scary, unless we sit outside, but what if it rains? So things like spacing in the eateries will need to be important. Sitting, do the tables become 1 to 2 meters diameter so that we are far enough? But then does that mean we will start talking loudly in the restaurants? Again, there are issues in terms of privacy. Then number 3, do we improve our ventilation? Because aircon will not do. Aircon circulates the air. It does not suck out the air or allow for free movement in and out. So those are some of the things we will need to consider. It may have been primarily an economic decision rather than a public health informed decision. So it's a whole. We have to be real. It's a whole, and we need to figure out how do we deal with it. And the worst thing about it, yes, there's hand hygiene, but you can't eat with a face mask on. I've really tried to process that. So as somebody speaks, you have these micro droplets from their mouth because they are passionate and they're enjoying. So we really need to rethink this as a system. It's a huge hole. And as I said, for healthcare workers, we, as Dr. Amit says, it's business unusual. We have now to go out and look for our patients rather than them come to look for us, and be really aggressive about just communicating that it is safe for them to come to the hospital to get the necessary care that they require. Maybe I can have some other thoughts from the team.
Yeah, I think that is exactly it, that we need to look at it from a, what are the different things that we have done to reduce the risk at at a public health level. Again, it's now Swiss cheese model applied on a macro scale in the country. For example, one, there's the lockdown, border controls or locking for the counties that have the highest risks. So already within Nairobi, we have Nairobi County or Mombasa County. One is to reduce the movement of people across borders. Two is to ensure that not so many people are going to work, so there's still a lot of encouragement for work from home. Three, then that means then there's the reduction in the number of people that can use one means of public transport or even private transport at any given time. So those are different factors that will reduce the habits of the population in a manner that it will reduce the ease of transmission of the virus, as well as even if the virus is transmitted, it is at a much lower level than it would be if we completely resumed our lives back to normal. Then there's even simple things as schools remaining shut, because schools alone actually, just for their operations, cause a lot of movement within the county. So in terms of transmittability of the disease, it goes up, and especially if we consider that children are very efficient transmitters of the disease, even if they themselves are supposedly low risk for severe disease or even symptomatic COVID-19. So I think the Swiss cheese model has been applied on a macro scale. And because, again, I think one of the greatest things that has come up with the COVID-19 is that so many aspects of our lives are interlinked. The moment you don't have food, then your immunity goes down, and then you become even more susceptible to severe forms of the disease. So, or you're likely to have a different health-seeking behavior. For example, you'd be probably going to the hospital when it's really, really late. So that we need to look at economic aspects of the population and see how can we cushion that by allowing those who can still work safely to go back to work, so that then there's still some financial cushioning for them. And for the vulnerable, you've seen that we have given as a country some reprieve by some disbursement of funds to the vulnerable population in the community. So all these things enable, to some extent, some level of return of normalcy. But then again, we would want to, again, acknowledging our own shortfalls as a country, and acknowledging especially the limitations in resources, because it is for a reason that maybe our eateries are not as fancy. Like, I mean, with every major town within Nairobi or a center, you will have the formal eateries that are clean, well aerated, and then there's the shanty eateries, and they thrive because there's actually a demand for them. So how do we then do other things that, although we still need to use them, we would reduce the risk of the population when they do use them? Yeah, so it's a big, it's a broad discussion, and we're learning as we go and trying to make the most of the situation that we find ourselves in. That's how to look at it here.
Thank you, Dr. Sitonik. A quick question from Kesia Odemba. She's saying, how are we managing those who are in isolation? Are we giving them some immune boosting treatment or something? And why are we not, this is what he's asking, why are we not developing homegrown solutions like things that are happening in Senegal, Madagascar, and the like?
So I will presume they're asking isolation in institutional quarantine.
Yes, they're asking,
because
they're saying, how are we looking after them? Those ones who are in isolation, those who are in quarantine, how are we giving them a diet that is boosting their immunity, or we are just waiting? Or what are we doing in terms of homemade solutions?
Okay, so treatment of flu I think remains the same even with COVID-19. It's just that if the patient tests positive, then we go and utilize the treatment protocol, which is using either your hydroxychloroquine, chloroquine, and your oseltamivir. So in that regard, then that's the treatment that's being given because it's the treatment that has been accepted globally. Can we use our own homegrown? Yes, we can. But has it been tested so that we can say we are going to definitely give our patients our own homegrown? No, it hasn't. Unfortunately, and this is the challenge of modern medicine, we are scientists. We are hypothesis-driven and evidence-based. So it will be difficult during a pandemic to now put the lives of our population at risk. But that being said, where they require vitamin C and multivitamins to boost their immunity, rest, psychosocial support, sedatives, as I said, because you have to also respond to the patient according to the uniqueness of what they need, that is ongoing in the various centers. Are there homegrown solutions? Yes, we've seen, and allow me to just refer to, and this may not be in isolation per se, a technical university in Mombasa that came up with a spraying plant as people walk towards the ferry. That's a homegrown solution that has been borrowed from the UAE, for example. You have seen places like Aga Khan and Kijabe put up 100-bed hospitals. I think it was KU, was it JKUAT, that came up with ventilator that can ventilate 3 to 7 patients. It doesn't look fancy, not at all, but at least it's able to ventilate those lungs. So we are trying. The truth is, as I had mentioned earlier, it's a paradigm shift. Remember, we are a country that's used to getting funding for malaria, TB, HIV, you know, and even for cancer, we rely a lot on donor funding. So we are very innovative in terms of ideas of how to implement the donor funding and stretch it far. But we need to go further back upstream and now start innovating and saying, I don't have the donor funding. I must come up with a way to ensure that we can get treatment for this. And therefore, as a nation that is used to receiving reactive, and remember I had talked about last week, what's our kind of response? Are we dormant? Are we proactive? Or are we reactive? Now we are having to think of how to be proactive because we have been reactive in how we deal with issues as a country. So it's a big change for us. And even as I said, as healthcare workers or facilities, we sit and wait for patients to come. But now we have to go out and check on patients. It's no longer a supplier-driven market. Now we have to go and it has to be a patient or client-driven market. So and we have to do things differently. Yeah.
Thank you, Dr. Joanne. Participants and panelists, we are getting to the end of the session. I would like to give a feedback. The questions are, as we've discussed, I think we've not left out any question. I wanted us to go into a round of closing remarks so that we are able to move to the next. I know many people have series of meetings coming up. I will start with the Ken, then Dr. Sitonik, then finally Dr. Joanne, and then we'll be able to have this meeting come to an end. Ken.
Thank you very much, Walter. The question by Kezia, if I may start with that one. Kenya has a lot of innovations and a lot of homegrown solutions. It's only that they have not been highlighted by the mainstream media so that most of the people can see what the Kenyans are doing. For example, if you go to JKUAT, they do have a model that can be able to tell us in actual sense, how far we are going with COVID on a daily basis. So it's only that we've not been informed that JQuat is doing that. And also, as Dr. Joanne has mentioned, yes, we do have our technical institutions and the universities that has really done quite a massive amount of work with regards to the ventilators. As soon as Kenyans came up with, the students came up with the ventilators for 4 patients, you saw that NASA from the American space developed the similar thing, right? Which is even cheaper. They were saying it was, I don't know, $28 or something, right? So we have a lot of homegrown solution. Ghana came up with the textile industry, which we are doing in NYS, which we're also doing in Kitui, and we are doing in other counties as well. And I think that's why everybody now has something to put on their face in form of a mask, right? It's only that KEBS hasn't come in strongly to say that they have said that their mask have met certain standards. Now going to the discussion taken through by Dr. Joanne, yes, we have to know the slices that we do have so that we really can tell the holes they are in and how we can be able to fill them. And I believe that Kenya stands a very good chance because we have a very collaborative people in terms of wananchi, but they are very much on social media. If we can also target the social media with all this information so that they can learn from there. And I believe that with COVID, we can be able to defeat it. And thank you once again, fellow panelists and participants for coming through.
Thank you, Ken. Dr. Sitoni?
Okay, I think I'd like to thank my fellow panelists for their contribution, and especially Dr. Joanne for a very insightful discussion right from the first one to this one, building up on the first one at what we can do at the immediate operational level within the hospital, and then now on a broader perspective. So I think with this, our participants are better placed to see how to either advise their facilities or to support the management team in their facilities, and also to advise the public or their patients on the safety measures that they have taken to ensure that they can access their usual health services safely. So thank you, and we look forward to more discussions in future.
Thank you, Dr. Sitoni. Our chief panelists today, as you answer, maybe you can also give an insight of what participants could expect in the coming days.
Thank you, Walter. I think going forward, we will focus more on the areas that the ministry raises as red flags, areas where we can process and also be part of the solution. Because I believe if we wait for someone to give us a solution, we may not be. There's a big challenge with tracing and how to handle managing of asymptomatic patients, especially in the populous areas. So as healthcare workers, what can we do where we are? And then how can we be more creative in rebuilding our businesses and getting more patients on board? I think that's very key. Thank you.
Thank you, Dr. Joanne. So as we come to the end, participants and panelists, it's also important to note, as the discussion have been coming forth, I realize that there is something that can be done at national level, at organizational level, at department level, at a technical level, at a group level, at maybe a small unit where you work, and there's something you can do individually. So we appreciate you for having been part of this journey, and we look forward to having you again coming Thursday from 2 to 3 and Friday, and we'll be able to also share more on the insights of how to combat COVID-19. A closing word for me is, there's someone who once told me that in order for you to achieve something, there must be something ahead of you that is challenging. And he puts it this way, that you need a Goliath in life to unleash the David in you. So let's, as health workers, also look at COVID as an opportunity to unleash unhidden potential, talent, opportunity showcase, document, and be able to share something that can change and becomes a contribution you can do to our motherland, our nation, Kenya, and in humanity in general. So wish you all the best as we look forward to many interventions and many engagement in the future. And when opportunities arise, it is those who are ready to take up the opportunities, those who are bold enough. Thank you for being here. God bless, and let's have another wonderful session coming Thursday. Thank you, everyone.